Chest CT is done to evaluate for an evolving abscess because pneumatossals may become infected. CT-guided catheter drainage may be required in such cases because 25% of patients do not respond to antibiotic therapy alone. Surgery, ranging from partial resection to anatomic lobectomy, is indicated for unresolving complex pneumatossals or infected lesions refractory to antibiotic therapy and drainage. The most common complication after thoracic injury is development of an MPM. Management is based on CT diagnostic criteria. 110. Percutaneous drainage is indicated for a single localization without appreciable rhyme. While fibrinolytics are often used for MPM, there is a paucity of data to support their use. Early decortication via video-assisted thoracic surgery should be done promptly in patients with multiple loculations or a pleural rind of 1 cm. 111. Antibiotic treatment is based on definitive culture results, but presumptive antibiotics should cover MRSA in the sick esophagus. Due to the proximity of the structures, esophageal injuries often occur with tracheobronchial injuries, particularly in cases of penetrating trauma. Operative options are based on the extent and location of esophageal injury. With sufficient mobilization, a primary single-layer end-to-end anastomosis may be performed after appropriate debridement. As with cervical repairs, if there are two suture lines in close approximation trachea or bronchi and esophagus, interposition of a vascularized pedicle is warranted to prevent fistula formation. Perforations at the gastroesophageal junction may be treated with repair and Nissen fundoplication or, for destructive injuries, segmental resection and gastric pull-up. Small esophageal injuries can be managed with stenting. With large destructive injuries or delayed presentation of injuries, esophageal exclusion with wide drainage, diverting loop esophagostomy, and placement of a gastrostomy tube should be considered. Chest wall and diaphragm. Virtually all chest wall injuries, consisting of rib fractures and laceration of intercostal vessels, are treated non-operatively with pain control, pulmonary toilet or ventilatory management, and drainage of the pleural space as indicated. Early institution of effective pain control is essential. The authors advocate preemptive rib blocks with 0.25% bupivacaine hydrochloride Marcaine in the trauma bay, followed by thoracic wall pain catheters. 112. Epidural anesthesia is reserved for multiple segmental fractures. Persistent hemorrhage from a chest tube after blunt trauma most often is due to injured intercostal arteries. For unusual persistent bleeding, see Table 710. Thoracotomy with direct ligation or angioembolization may be required to arrest hemorrhage. In cases of extensive flailed chest segments, markedly displaced by cortical rib fractures, or loss of 20% of the thoracic volume, open reduction and internal fixation of the fracture with plates may be warranted. Chest wall defects, particularly those seen with open pneumothorax, are repaired using local approximation of tissues or tissue transfer for coverage. Scapular and sternal fractures rarely require operative intervention but are markers for significant thoracoabdominal force during injury. Significant displacement may benefit from sternal plating fig. 759. Careful examination and imaging should exclude associated injuries, including blunt cardiac injury and descending BAI. On the other hand, clavicle fractures are often isolated injuries and should be managed with pain control and immobilization. The exception is posterior dislocation of the clavicular head, which may injure the subclavian vessels. Blunt diaphragmatic injuries usually result in a linear tear, and most injuries are large, whereas penetrating injuries are variable in size and location depending on the agent of injury. Regardless of the etiology, acute injuries are usually repaired through an abdominal approach to manage potential associated visceral injury. After delineation of the injury, the chest should be evacuated of all blood and particulate matter, and a thoracostomy tube placed if not previously done. Alice clamps are used to approximate the diaphragmatic edges, and the defect is closed with a running no. 1 polypropylene suture. Occasionally, large avulsions or shotgun wounds with extensive tissue loss will require polypropylene or biologic mesh to bridge the defect. 225. Chapter 7. Trauma. A B figure 759. Significant sternal displacement A. Arrows can be reduced and stabilized with sternal plating B. Alternatively, transposition of the diaphragm cephalad 1 to 2 intercostal spaces may allow repair without undue tension. 73. Abdominal injuries, liver and extrahepatic biliary tract. The liver's large size makes it the organ most susceptible to blunt trauma, and it is frequently involved in upper torso penetrating wounds. Non-operative management of solid organ injuries is pursued in hemodynamically stable patients who do not have overt peritonitis or other indications for laparotomy. Patients with grade Roman II injury should be admitted to the sickle with frequent hemodynamic monitoring, determination of hemoglobin, and abdominal examination. The only absolute contraindication to non-operative management is hemodynamic instability from intraperitoneal hemorrhage. Factors such as high injury grade, large hemoperitoneum, contrast extravasation, or pseudoaneurysms may predict complications or failure of non-operative management. Angioembolization and endoscopic retrograde cholangiopan creatography ERC are useful adjuncts that can improve the success rate of non-operative management. 113,114. The indication for angiography to control a hepatic hemorrhage is transfusion of 4 units of RBCs in 6 hours or 6 units of RBCs in 24 hours attributable to the liver. In the 15% of patients for whom emergent laparotomy is mandated, the primary goal is to arrest hemorrhage. Initial control of hemorrhage is best accomplished using perihepatic packing and manual compression. The edges of the liver laceration should be opposed for local pressure control of bleeding. Hemorrhage from most major hepatic injuries can be controlled with effective perihepatic packing. The right costal margin is elevated, and the pads are strategically placed over and around the bleeding site. See Fig. 737. Additional pads should be placed between the liver, diaphragm, and anterior chest wall until the bleeding has been controlled. Sometimes 10 to 15 pads may be required to control the hemorrhage from an extensive right lobar injury. Packing of injuries of the left lobe is not as effective because there is insufficient abdominal and thoracic wall interior to the left lobe to provide adequate compression with the abdomen open. Fortunately, hemorrhage from the left lobe usually can be controlled by mobilizing the lobe and compressing it between the surgeon's hands. With extensive injuries and major hemorrhage, a Pringle maneuver should be done immediately. Intermittent release of the Pringle is helpful to attenuate hepatic cellular loss. If the patient has persistent bleeding despite packing, injuries to the hepatic artery, portal vein, and retrohepatic vasculature should be considered. A Pringle maneuver can help delineate the source of hemorrhage. Hemorrhage from hepatic artery and portal vein injuries will halt with the application of a vascular clamp across the portal triad, whereas bleeding from the hepatic veins and the retrohepatic vena cava will continue despite a Pringle maneuver. Injuries of the portal triad vasculature should be addressed immediately. In general, ligation from the celiac axis to the level of the common hepatic artery at the gastroduodenal arterial branch is tolerated due to extensive collaterals, but the proper hepatic artery should be repaired. The right or left hepatic artery, or in urgent situations the portal vein, may be selectively ligated. Occasionally, lobar necrosis will necessitate delayed anatomic resection. If the right hepatic artery is ligated, cholecystectomy also should be performed. If the vascular injury is a stab wound with clean trisection of the vessels, primary end repair is done. If the injury is destructive, temporary shunting should be performed followed by interposition reverse saphenous vein graft or SVG. Blunt avulsions of the portal structures are particularly problematic if located at the hepatic plate, flush with the liver. Hemorrhage control at the liver can be attempted with directed packing or Fogarty catheters. If injury to the portal triad vasculature is more proximal, at the superior border of the pancreatic body or even retropancreatic, the pancreas must be transected to gain access for hemorrhage control and repair. If massive venous hemorrhage is seen from behind the liver despite use of the Pringle maneuver, the patient likely has a hepatic vein or retrohepatic vena cava injury. If bleeding can be controlled with perihepatic packing, the packing should be left undisturbed and the patient observed in the sickle. Placement of a hepatic vein stent by interventional radiology may be considered. If bleeding continues despite repeated attempts at packing, then direct repair, with or without hepatic vascular isolation, should be attempted. 3 techniques have been used to accomplish hepatic vascular isolation: a direct repair with suprahepatic and infrahepatic clamping of the vena cava and stapled-assisted parenchymal resection on 115, B. Temporary shunting of the retrohepatic vena cava, and C. Venovenous bypass Fig. 760. 116. A number of methods for the definitive control of hepatic parenchymal hemorrhage have been developed. Minor lacerations may be controlled with manual compression applied directly to the injury site. Topical hemostatic techniques include 226 Part I. Basic considerations. Figure 760. Venovenous bypass permits hepatic vascular isolation with continued venous return to the heart. IV equals inferior mesenteric vein. IVC equals inferior vena cava. SMV equals superior mesenteric vein. The use of an electrocautery with the device set at 100 watts, argon beam coagulator, microcrystalline collagen, thrombin soaked gelatin foam sponge, fibrin glue, and bioglue. Suturing of the hepatic parenchyma with a blunt-tipped zero-chromic suture, for example. A liver suture can be an effective hemostatic technique. A running suture is used to approximate the edges of shallow lacerations, whereas deeper lacerations are approximated using interrupted horizontal mattress sutures placed parallel to the edge of the laceration. When the suture is tied, tension is adequate when visible hemorrhage ceases or the liver blanches around the suture. Caution must be used to prevent hepatic necrosis. This technique of placing large liver sutures controls bleeding through reapproximation of the liver laceration rather than direct ligation of bleeding vessels. Aggressive finger fracture to identify bleeding vessels followed by individual clip or suture ligation was indicated previously but currently has a limited role in hemostasis. Hepatic lobar arterial ligation may be appropriate for patients with recalcitrant arterial hemorrhage from deep within the liver and is a reasonable alternative to a deep hepatotomy, particularly in unstable patients. Omentum can be used to fill large defects in the liver. The tongue of omentum not only obliterates potential dead space with viable tissue but also provides an excellent source of macrophages. Additionally, the omentum can provide buttressing support for parenchymal sutures. Translobar penetrating injuries are particularly challenging because the extent of the injury cannot be fully visualized. As discussed in damage control surgery, options include intraparenchymal tamponade with a Foley catheter or balloon occlusion C. Fig. 7.49117. If tamponade is successful with either modality, the balloon is left inflated for 24 to 48 hours, followed by sequential deflation and removal as second laparotomy. Hepatotomy with ligation of individual bleeders occasionally may be required. However, division of the overlying viable hepatic tissue may cause considerable blood loss in the coagulopathic patient. Finally, embolization is an effective adjunct in any of these scenarios and should be considered early in the course of treatment. Several centers have reported patients with devastating hepatic injuries or necrosis of the entire liver who have undergone successful hepatic transplantation. 118. Clearly this is dramatic therapy, and the patient must have all other injuries delineated, particularly those of the central nervous system, and have an excellent chance of survival excluding the hepatic injury. Because donor availability will limit such procedures, hepatic transplantation for trauma will continue to be performed only in extraordinary circumstances. Cholecystectomy is performed for injuries of the gallbladder and after operative ligation of the right hepatic artery. Injuries of the extrahepatic bile ducts are a challenge due to their small size and thin walls. Because of the proximity of other portal structures and the vena cava, associated vascular injuries are common. These factors may preclude primary repair. Small lacerations with no accompanying loss or devitalization of adjacent tissue can be treated by the insertion of a T-tube through the wound or by lateral suturing using 6-0 monofilament absorbable suture. Virtually all transections and any injury associated with significant tissue loss will require a root NY cholecystectomy. The anastomosis is performed using a single-layer interrupted technique with 5-0 monofilament absorbable suture. To reduce anastomotic tension, the jejunum should be sutured to the areolar tissue of the hepatic pedicle or porta hepatis. Injuries of the hepatic ducts are almost impossible to satisfactorily repair under emergent circumstances. One approach is to intubate the duct for external drainage and attempt to repair when the patient recovers or attempt stenting via ERC. Alternatively, the duct can be ligated if the opposite lobe is normal and uninjured. Patients undergoing perihepatic packing for extensive liver injuries typically are returned to the OR for pack removal 24 hours after initial injury. Earlier exploration may be indicated in patients with evidence of ongoing hemorrhage. Signs of rebleeding are usually conspicuous and include a falling hemoglobin, accumulation of blood clots under the temporary abdominal closure device, and bloody output from drains. The magnitude of hemorrhage is reflected in ongoing hemodynamic instability and metabolic monitoring. Postoperative hemorrhage should be reevaluated in the OR once the patient's coagulopathy is corrected. Alternatively, angioembolization is appropriate for complex injuries. Patients with hepatic ischemia due to prolonged intraoperative use of the Pringle maneuver have an expected elevation but subsequent resolution of transaminase levels, whereas patients requiring hepatic artery ligation may have frank hepatic necrosis. Although febrile patients should be evaluated for infectious complications, patients with complex hepatic injuries typically have intermittent liver fever for the first 5 days after injury. Aside from hemorrhage and hepatic necrosis, additional complications after significant hepatic trauma include bilomas, arterial pseudoaneurysms, and biliary fistulas. Fig. 761. Bilomas are loculated collections of bile, which may or may not be infected. If infected, they should be treated like an abscess via percutaneous drainage. Although small, sterile bilomas, 1107.5, or 150-330, 0.0, ABC News, 10 centimeters, figure 761. Complications after hepatic trauma include bilomas A, arrow, hepatic duct injuries B, and hepatic necrosis after hepatic artery ligation or embolization C. Eventually will be REAPS. Larger fluid collections should be drained. Biliary sites, due to the disruption of a major bile duct, often requires reoperation and wide drainage. Primary repair of the injured intrahepatic duct is unlikely to be successful. Resectional debridement is indicated for the removal of peripheral portions of non-viable hepatic parenchyma. Chapter 7. Pseudoaneurysms and biliary fistulas are rare, complica 227 times in patients with hepatic injuries. Because hemorrhage from hepatic injuries often is treated without isolating individual bleeding vessels, arterial pseudoaneurysms may develop with the potential for rupture. Rupture into a bile duct results in hemophilia, which is characterized by intermittent episodes of right upper quadrant pain, upper GI hemorrhage, and jaundice. If the aneurysm ruptures into a portal venous hypertension with bleeding esophageal varices may occur. Either scenario is best managed with hepatic arteriography and embolization. Ileovenous fistulas, causing jaundice due to rapid increases in serum bilirubin levels, should be treated with ERC and sphincterotomy. Rarely, a biliary fistula's communication will form with intrathoracic structures in patients with associated diaphragm injuries, resulting in a bronchobiliary or pleurobiliary fistula. Due to the pressure differential between the biliary tract positive and the pleural cavity negative, the majority require operative closure. Occasionally, endoscopic sphincterotomy with stent placement will be required to address the pressure differential, and the pleurobiliary fistula will close spontaneously. Spleen. Until the 1970 seconds, splenectomy was considered mandatory for all splenic injuries. Recognition of the immune function of the spleen refocused efforts on operative splenic salvage in the 1980-19120. After demonstrated success in pediatric patients, non-operative management has become the preferred means of splenic salvage for all patients. The identification of contrast extravasation as a risk factor for failure of non-operative management led to liberal use of angioembolization. The role of selective angioembolization SA continues to be defined, but appears warranted in high-grade injuries, particularly those with contrast blush. 121. It is clear, however, that up to 15% to 20% of patients with splenic trauma warrant early splenectomy and that failure of non-operative management often represents inappropriate patient selection. 122,123 indications for early intervention in adults include initiation of blood transfusion within the first 12 hours and hemodynamic instability. Unlike hepatic injuries, which usually rebleed within 48 hours, delayed hemorrhage or rupture of the spleen can occur up to weeks after injury. Splenic injuries are managed operatively by splenectomy, partial splenectomy, or splenic repair splenography, based on the extent of the injury and the physiologic condition of the patient. Splenectomy is indicated for significant hilar injuries, pulverized splenic parenchyma, or any grade Roman II injury in a patient with coagulopathy or multiple life-threatening injuries. The authors use autotransplantation of splenic implants. Fig. 762 to achieve partial immunocompetence in younger patients who do not have an associated enteric injury. Drains are not used. Partial splenectomy can be employed in patients in whom only the superior or inferior pole has been injured. Hemorrhage from the raw splenic edge is controlled with horizontal mattress sutures, with gentle compression of the parenchyma. Fig. 763. During splenography, hemostasis is achieved by topical methods: electrocautery, argon beam coagulation, application of thrombin, stoked gelatin foam sponges, fibrin glue, or bioglue, envelopment of the injured spleen and absorbable mesh, and pledgeted suture repair. After splenectomy or splenography, postoperative hemorrhage may be due to an improperly ligated or unrecognized short gastric artery, or recurrent bleeding from the splenic parenchyma if splenic repair was used. An immediate postsplenectomy. Trauma 228 Part I. Basic considerations Figure 762. Autologous splenic transplantation is performed by placing sections of splenic parenchyma, 40 times 40 times 3 mm in size, into pouches in a greater omentum. Increase in platelets and WBCs is normal. However, beyond postoperative day 5, a WBC count above 15,000/mm3 and a platelet/WBC ratio of 20 are associated with sepsis and should prompt a thorough search for underlying infection. 124 A common infectious complication after splenectomy is a subphrenic abscess, which should be managed with percutaneous drainage. Additional sources of morbidity include a concurrent or unrecognized iatrogenic injury to the pancreatic tail during rapid splenectomy resulting in pancreatic ascites or fistula, or gastric perforation during short gastric vessel ligation. Enthusiasm for splenic salvage was driven by the rare, but often fatal, complication of overwhelming postsplenectomy sepsis. Overwhelming postsplenectomy sepsis is caused by encapsulated bacteria, Streptococcus pneumoniae, Haemophilus influenzae, and Neisseria meningitidis, which are resistant to antimicrobial treatment. In patients undergoing splenectomy, prophylaxis against these bacteria is provided via vaccines administered optimally at 14 days post-injury. 125. Stomach and small intestine. Little controversy exists regarding the repair of injuries to the stomach or small bowel because of a rich blood supply. Gastric wounds can be oversewn with a running single-layer suture line or closed with a stapler. If a single-layer closure is chosen, full-thickness bites should be taken to ensure hemostasis from a well-vascularized gastric. Figure 763. Interrupted pledgeted sutures may effectively control hemorrhage from the cut edge of the spleen. The most commonly missed gastric injury is the posterior wound of a through-and-through penetrating injury. Injuries also can be overlooked if the wound is located within the mesentery of the lesser curvature or high in the fundus. To delineate a questionable injury, the stomach can be digitally occluded at the pylorus while methylene blue-colored saline is instilled via a nasogastric NG tube. Alternatively, air can be introduced via the NG tube with the abdomen filled with saline. Partial gastrectomy may be required for destructive injuries, with resections of the distal antrum or pylorus reconstructed using a Billroth procedure. Patients with injuries that damage both lateral nerves or vagi should undergo a drainage procedure. See Chapter 26. Small intestine injuries can be repaired using a transverse running 3/0 PDS suture if the injury is less than 1/3 the circumference of the bowel. Destructive injuries or multiple penetrating injuries occurring close together are treated with segmental resection followed by end-to-end anastomosis using a continuous, single-layer 3/0 polypropylene suture. 55. Mesenteric injuries may result in an ischemic segment of intestine, which mandates resection. Following repair of GI tract injuries, patients may develop a postoperative ileus. Return of bowel function is indicated by a decrease in gastrostomy or nasogastric tube output. The topic of nutrition is well covered in other chapters. See Chapter 2, but a few issues warrant mention. Multiple studies have confirmed the importance of early total enteral nutrition 10 in the trauma population, particularly its impact in reducing septic complications. 126. The route of enteral feeding stomach versus small bowel tends to be less important because gut tolerance appears equivalent unless there is upper GI tract pathology. Although early enteral nutrition is the goal, evidence of bowel function should be apparent before advancing to goal tube feedings. Overzealous jejunal feeding can lead to small bowel necrosis in the patient recovering from profound shock. Patients undergoing monitoring for non-operative management of grade Roman 3 or higher solid organ injuries should receive nothing by mouth for at least 48 hours in case they require an operation. Although there is general reluctance to initiate 10 in patients with an open abdomen, a recent multicenter trial demonstrates that 10 in the post-injury open abdomen is feasible. 127. For those patients without a bowel injury, 10 was associated with higher facial closure rates, decreased complications, and decreased mortality. 10 in patients with 229 trauma bowel injuries does not appear to alter facial closure rates, complications, or mortality. Hence, N appears to be neither advantageous nor detrimental in these patients. Once resuscitation is complete, initiation of 10, even at trophic levels 20 ml/H, should be considered in all injured patients with an open abdomen. Duodenum and pancreas. The spectrum of injuries to the 7 duodenum includes hematomas, perforation blunt blowouts, lacerations from stab wounds, or blast injury from gunshot wounds, and combined pancreaticoduodenal injuries. The majority of duodenal hematomas are managed non-operatively with nasogastric suction and parenteral nutrition. Patients with suspected associated perforation, suggested by clinical deterioration or imaging with retroperitoneal free air or contrast extravasation, should undergo operative exploration. Marked drop in nasogastric tube output heralds resolution of a hematoma, which typically occurs within 2 weeks. Repeat imaging to confirm these clinical findings is optional. If the patient shows no clinical or radiographic improvement within 3 weeks, operative evaluation is warranted. Small duodenal perforations or lacerations should be treated by primary repair using a running single-layer suture of 3/0 monofilament. 128. The wound should be closed in a direction that results in the largest residual lumen. Challenges arise when there is a substantial loss of duodenal tissue. Extensive injuries of the first portion of the duodenum proximal to the figure 764. Roux-en-y duodenogenostomy is used to treat duoductive Santorini can be repaired by debridement and N2, Duodenal injuries between the papilla vader and superior mesenteric anastomosis because of the mobility and rich blood supply vessels when tissue loss precludes primary repair of the distal gastric atrium and pylorus. In contrast, the second portion is tethered to the head of the pancreas by its blood supply in the ducts of Wirsing and Santorini. Therefore, no more than 1 cm of duodenum can be mobilized away from the pancreas. Traverses this area and often converges with the pancreatic duct. Moreover, suture repair using an end-to-end anastomosis in contrast to diagnosis of pancreatic duct injuries, adenificus portion often results in an unacceptably narrow lumen. Count of intrapancreatic common bile duct disruption is relatively therefore. Defects in the second portion of the duodenum should simple. The first method is to squeeze the gallbladder and lip be patched with a Roux-en-Y duodenogenostomy. Duodenum for bile leaking from the pancreatic wound. Otherwise, Schallen injuries with tissue loss distal to the papilla vader in proximal geography, optimally via the cystic duct, is diagnostic. Definitive to the superior mesenteric vessels are best treated by Roux-en. Treatment of this injury entails division of the common bile duct Y duodenogenostomy with the distal portion of the duodenum superior to the first portion of the duodenum with ligation of the ovosome fig. 764. In particular, injuries in the distal third and distal duct and reconstruction with the Roux-en-Y colichogefourth portions of the duodenum behind the mesenteric vessels nostomy. For injuries to the head of the pancreas that involve the should be resected, and a duodenogenostomy should be per main pancreatic duct but not the intrapancreatic bile duct. They're formed on the D3 side of the superior mesenteric vessels. A few options. Distal pancreatectomy alone is rarely indicated. Optimal management of pancreatic trauma is determined by due to the extended resection of normal gland and the resultant where the parenchymal damage is located and whether the risk of pancreatic insufficiency. Central pancreatectomy per pancreatic common bile duct and main pancreatic duct remain serves the common bile duct and mobilization of the pancreatic intact. Patients with pancreatic contusions defined as injuries that body permits drainage into a posterior wall pancreaticotis leave the ductal system intact can be treated non-operatively or trostomy or Roux-en-Y pancreaticogenostomy fig. 765. The parenchymal damage is located and whether the risk of pancreatic insufficiency. Central pancreatectomy per pancreatic common bile duct and main traverses this area and often converges with the pancreas. The spectrum of injuries to the duodenum includes hematomas, perforation blunt blowouts, lacerations from stab wounds, or blast injury from gunshot wounds, and combined pancreaticoduodenal injuries. The majority of duodenal hematomas are managed non-operatively with nasogastric suction and parenteral nutrition. Patients with suspected associated perforation, suggested by clinical deterioration or imaging with retroperitoneal free air or contrast extravasation, should undergo operative exploration. Marked drop in nasogastric tube output heralds resolution of the hematoma, which typically occurs within 2 weeks. Repeat imaging to confirm these clinical findings is optional. If the patient shows no clinical or radiographic improvement within 3 weeks, operative evaluation is warranted. Small duodenal perforations or lacerations should be treated by primary repair using a running single-layer suture of 30 monofilament. 128. The wound should be closed in a direction that results in the largest residual lumen. Challenges arise when there is a substantial loss of duodenal tissue. Extensive injuries of the first portion of the duodenum proximal to the duct of Santorini can be repaired by debridement and end-tone anastomosis because of the mobility and rich blood supply of the distal gastric atrium and pylorus. In contrast, the second portion is tethered to the head of the pancreas by its blood supply in the ducts of Wirsing and Santorini. Therefore, no more than 1 cm of duodenum can be mobilized away from the pancreas. Moreover, suture repair using an end-to-end anastomosis in the second portion often results in an unacceptably narrow lumen. Therefore, defects in the second portion of the duodenum should be patched with a Roux-en-Y duodenogenostomy. Duodenal injuries with tissue loss distal to the papilla vader and proximal to the superior mesenteric vessels are best treated by Roux-en-Y duodenogenostomy with the distal portion of the duodenum ovosome fig. 764. In particular, injuries in the distal third and fourth portions of the duodenum behind the mesenteric vessels should be resected, and a duodenogenostomy should be performed on the D3 side of the superior mesenteric vessels. Optimal management of pancreatic trauma is determined by where the parenchymal damage is located and whether the intrapancreatic common bile duct and main pancreatic duct remain intact. Patients with pancreatic contusions defined as injuries that leave the ductal system intact can be treated non-operatively or with closed suction drainage if undergoing laparotomy for other indications. Patients with proximal pancreatic injuries, defined as those that lie to the right of the superior mesenteric vessels, are also managed with closed suction drainage. 129. In contrast, distal pancreatic injuries are managed based upon ductal integrity. Pancreatic duct disruption can be identified through direct exploration of the parenchymal laceration, operative pancreatography, or magnetic resonance Challenge-Gap pancreatography. Patients with distal ductal disruption undergo distal pancreatectomy, preferably with splenic preservation. Injuries to the pancreatic head add substantial complexity because the intrapancreatic portion of the common bile duct. Figure 764. Roux-en-Y duodenogenostomy is used to treat duodenal injuries between the papilla vator and superior mesenteric vessels when tissue loss precludes primary repair. Traverses this area and often converges with the pancreatic duct. In contrast to diagnosis of pancreatic duct injuries, identification of intrapancreatic common bile duct disruption is relatively simple. The first method is to squeeze the gallbladder and look for bile leaking from the pancreatic wall. Otherwise, chalangography, optimally via the cystic duct, is diagnostic. Definitive treatment of this injury entails division of the common bile duct superior to the first portion of the duodenum with ligation of the distal duct and reconstruction with a Roux-en-Y cholecystogenostomy. For injuries to the head of the pancreas that involve the main pancreatic duct but not the intrapancreatic bile duct, there are few options. Distal pancreatectomy alone is rarely indicated due to the extended resection of normal gland and the resultant risk of pancreatic insufficiency. Central pancreatectomy preserves the common bile duct, and mobilization of the pancreatic body permits drainage into a posterior wall pancreatic cholecystrostomy or a Roux-en-Y pancreaticogenostomy. Fig. 765. Although this approach avoids a pancreatic duodenectomy Whipple procedure, the complexity may make the pancreatic duodenectomy more appropriate in patients with multiple injuries and is usually done in a damage control scenario. Some injuries of the pancreatic head do not involve either the pancreatic or common bile duct. If no clear ductal injury is present, drains are placed. Rarely, patients sustain destructive injuries to the head of the pancreas or combined pancreatic duodenal injuries that require pancreatic duodenectomy. Examples of such injuries include transection of both the intrapancreatic bile duct and the main pancreatic duct in the head of the pancreas, avulsion of the papilla vator from the duodenum, and destruction. Figure 765. For injuries of the pancreatic head that involve the with Roux-en-Y pancreaticogenostomy prevents pancreatic of the entire second portion of the duodenum. In these cases of extensive injuries, damage control principles are often employed. In contrast to proximal injuries, pancreatic resection continues to be indicated for major ductal disruption in the more distal pancreas. Several options exist for treating injuries of the pancreatic body and tail. In stable patients, spleen-preserving distal pancreatectomy should be performed. An alternative, which preserves both the spleen and distal transected end of the pancreas, is either a Roux-en-Y pancreaticogenostomy or pancreatic cholecystrostomy. If the patient is physiologically compromised, distal pancreatectomy with splenectomy is the preferred approach. Regardless of the choice of definitive procedure, the pancreatic duct and the proximal edge of transected pancreas should be individually ligated or occluded with a TA stapler. Application of fibrin glue over the stump may be advantageous. Pyloric exclusion may be used to divert the GI stream after high-risk, complex duodenal repairs, particularly with adjacent pancreatic injuries. Fig. 7.66130. If the duodenal repair breaks down, the resultant fistula is an end fistula, which is easier to manage and more likely to close than a lateral fistula. To perform a pyloric exclusion, first a gastrostomy is made on the greater curvature near the pylorus. The pylorus is then grasped with a Babcock clamp via the gastrostomy and oversewn with an O-polypropylene suture. Gastrojejunectomy restores GI tract continuity. Vagotomy is not necessary because a risk of marginal ulceration has not been documented. Perhaps surprisingly, the sutures maintain diversion for only 3 to 4 weeks. Alternatively, the most durable pyloric closure is a double external staple line across the pylorus using a TA stapler. Complications should be expected after major pancreatic duodenal injuries. 131. Late hemorrhage is rare but may spare the common bile duct. Central pancreatic resection occur with pancreatic necrosis or abdominal infection. This usually can be managed by angioembolization. If closed suction drains have been inserted for major pancreatic trauma, these should remain in place until the patient is tolerating an oral diet or enteral nutrition. Pancreatic fistula is diagnosed after postoperative day 5 in patients with drain output of 30 ml/d and a drain amylase level 3 times the serum value. Pancreatic fistula develops in over 20% of patients with combined injuries and should be managed similar to fistulas after elective surgery. See Chapter 33. Similarly, a duodenal fistula, presumptively an end fistula if a pyloric exclusion has been done, will typically heal in 6 to 8 weeks with adequate drainage and control of intra-abdominal sepsis. Pancreatic pseudocysts in patients managed non-operatively suggest a missed injury, and ERP should be done to evaluate the integrity of the pancreatic duct. Late pseudocysts may be a complication of operative management and are treated much like those in patients with pancreatitis. See Chapter 33. Intra-abdominal abscesses are common and routinely managed with percutaneous drainage. Colon and rectum. Currently, 3 methods for treating colonic injuries are used: primary repair, ankylostomy, and primary repair with diverting loop ileostomy. Primary repairs include lateral suture repair or resection of the damaged segment with reconstruction by ileocostomy or colecolostomy. All suturing and anastomosis are performed using a running single-layer technique. Fig. 767.55. The advantage of definitive treatment must be balanced against the possibility of anastomotic leakage if suture lines are created under suboptimal conditions. Alternatively, although use of an ankylostomy requires a second operation, an unprotected suture line with Figure 766a. Pyloric exclusion is used to treat combined injuries when the duodenal repair is less than optimal. B and C. To create a gastrojejunectomy, the authors frequently use Figure 767, technique for bowel repair and anastomosis. A. They are spaced 3 to 4 mm from the edge of the bowel and advanced 3 to tied near the intermesenteric border. The duodenum and the head of the pancreas, as well as isolated duodenal, is oversewn through a gastrotomy, which is subsequently used. Feeding jejunostomy tube feedings for these patients. Single layer suture is started at the mesenteric border. B. Stitches MM, including all layers except the mucosa. C. The continuous suture. Respective and several prospective studies have now clearly demonstrated that primary repair is safe and effective in virtually all patients with penetrating wounds. 132. Colostomy is still appropriate in a few patients, but the current dilemma is how to select which patients should undergo the procedure. Currently, the overall physiologic status of the patient, rather than local factors, directs decision-making. Patients with devastating left colon injuries requiring damage control have a leak rate of over 40% and may be candidates for temporary colostomy. 133. Averting ileostomy with cholecolostomy is another option for these high-risk patients. Rectal injuries are similar to colonic injuries with respect to the ecology of the luminal contents, overall structure, and blood supply of the wall, but access to extraperitoneal injuries is limited due to the surrounding bony pelvis. Therefore, indirect treatment with intestinal diversion usually is required. The current options are loop ileostomy and sigmoid loop colostomy. The latter is preferred because it is quick and easy to perform and provides essentially total fecal diversion. For sigmoid colostomy, technical elements include the adequate mobilization of the sigmoid colon so that the loop will rest on the abdominal wall without tension, the maintenance of the spur of the colostomy, the common wall of the proximal and distal limbs after maturation above the level of the skin with a 1/2 inch Penrose drain or similar device, see longitudinal incision in the tinea coli, and the immediate maturation in the OFIG. 768. If the injury is accessible, for example, in the posterior intraperitoneal portion of the rectum, repair of the injury should also be attempted. However, it is not necessary to explore the extraperitoneal rectum to repair a distal perforation. If the rectal injury is extensive, another option is to divide the rectum at the level of the injury, oversew or staple the distal rectal pouch if possible, and create an end colostomy Hartmann's procedure. Extensive injuries may warrant prosacral drainage with Penrose drains placed along wall layers fascia via a perineal incision, see Fig. 768, but routine prosacral drainage and rectal washout is no longer practiced. In rare instances in which, figure 768, loop colostomy will completely divert the fecal flow, allowing the low rectal injury to heal. For extensive wounds, prosacral drains are inserted through a perineal incision box and advanced along wall layers fascia dash line. May be necessary to avert lethal pelvic sepsis. Complications related to colorectal injuries include intra-abdominal abscess, fecal fistula, wound infection, and stomal complications. Intra-abdominal abscesses occur in approximately 10% of patients, and most are managed with percutaneous drainage. Fistulas occur in 1% to 3% of patients and usually present as an abscess or wound infection with subsequent continuous drainage of fecal output. The majority will heal spontaneously with routine care, see Chapter 29. Stomal complications, necrosis, stenosis, obstruction, and prolapse occur in 5% of patients and may require either immediate or delayed reoperation. Stomal necrosis should be carefully monitored because spread beyond the mucosa may result in septic complications, including necrotizing fasciitis of the abdominal wall. Penetrating injuries that involve both the rectum and adjacent bony structures are prone to development of osteomyelitis. Bone biopsy is performed for diagnosis and bacteriologic analysis, and treatment entails long-term Roman IV antibiotic therapy and occasionally debridement. Abdominal and pelvic vasculature. Injury to the major arteries and veins in the abdomen can be a technical challenge. 132-137. Although penetrating trauma indiscriminately affects all blood vessels, blunt trauma most commonly involves renal vasculature and occasionally the abdominal aorta. Patients with a penetrating aortic wound who survive to reach the or frequently have a contained hematoma within the retroperitoneum. Due to lack of mobility of the abdominal aorta, few injuries are amenable to primary repair. Supraceliac aortic wounds are particularly challenging due to the need for proximal control. Small lateral perforations may be controlled with 4-0 polypropylene suture or a PTFE patch, but end-to-end interposition grafting with a PTFE tube graft is the most common repair. Blunt injuries are typically extensive intimal tears of the infrarenal aorta with resultant thrombosis, and are exposed via a direct approach. Most require an interposition graft. To avoid future vascular enteric fistulas, the vascular suture line should be covered with omentum. SMA are typically encountered after exploration for a gunshot wound, with black bile and associated supramesenteric hematoma being pathognomonic. Blunt avulsions of the SMA are rare but should be considered in patients with a seatbelt sign who have mid-epigastric pain or tenderness and associated hypotension. For injuries of the SMA, temporary damage control with a prute in the RS shunt can prevent extensive bowel necrosis. For definitive repair, end-to-end interposition or SVG from the proximal SMA to the SMA past the point of injury can be performed if there is no associated pancreatic injury. Alternatively, if the patient has an associated pancreatic injury, the graft should be tunneled from the distal aorta beneath the duodenum to the distal SMA. For proximal SMV injuries, digital compression for hemorrhage control is followed by attempted venorrhaphy. Ligation is an option in a life-threatening situation, but the resultant bowel edema requires aggressive fluid resuscitation. Temporary abdominal closure and a second look operation to evaluate bowel viability should be done. Transpelvic gunshot wounds or blunt injuries with associated pelvic fractures are the most common scenarios in patients with iliac artery injuries. As with abdominal vascular injuries, a prute in the RS shunt can be used for temporary shunting of the vessel for damage control. Definitive interposition grafting with excision of the injured segment is appropriate. See vascular repair techniques. Careful monitoring for distal embolic events and reperfusion injury necessitating fasciotomy is imperative. In general, outcome after pelvic vascular injuries is related to the technical success of the vascular reconstruction and the associated soft tissue and nerve injuries. Vascular repairs rarely. Figure 769. When rhinorrhaphy is undertaken, effective repair is bleeding and permits adequate visualization. B. The renal capsule absorbable suture. E. The preserved capsule is closed over the thread for several weeks. Following aortic interposition grafting, the patient's SPP should not exceed 120 mmHg for at least the first 72 hours postoperatively. Patients requiring ligation of an inferior vena cava injury often develop marked bilateral lower extremity edema. To limit the associated morbidity, the patient's legs should be wrapped with elastic bandages from the toes to the hips and elevated. For superior mesenteric vein injuries, either ligation or thrombosis after venorrhaphy results in marked bowel edema. Fluid resuscitation should be aggressive and abdominal pressure monitoring routine in these patients. Prosthetic graft infections are rare complications, but prevention of bacteremia is imperative. VID2. Administration of antibiotics perioperatively and treatment of secondary infections is indicated. Long-term arterial graft complications, such as stenosis or pseudoaneurysms, are uncommon, and routine graft surveillance rarely is performed. Consequently, long-term administration of antiplatelet agents or antithrombotics is not routine. Genitourinary tract. Historically, when undergoing laparotomy for trauma, all penetrating wounds to the kidneys were explored. Recently, routine exploration of Gerald's fascia has been questioned. 138,139. Parenchymal renal injuries are treated with hemostatic and reconstructive techniques similar to those used for injuries of the liver and spleen. Topical methods: electrocautery, argon beam coagulation, application of thrombin-soaked gelatin foam sponge, fibrin glue, or bioglue, and pledgeted suture repair. However, two caveats are recognized. The collecting system should be closed separately, and the renal capsule should be preserved to close over the repair of the collecting system. Fig. 769. Renal vascular injuries are common after penetrating trauma and may be deceptive due to tamponade by Gerald's. My attention to several key points. A. Vascular occlusion controls preserved. C. The collecting system is closed separately with system repair. Using graft interposition should be attempted within 5 hours of injury for renal preservation. For destructive parenchymal or irreparable renovascular injuries, nephrectomy may be the only option. A normal contralateral kidney must be palpated because unilateral renal agenesis occurs in 0.1% of patients. Over 90% of blunt renal injuries are treated non-operatively. Hematuria typically resolves within a few days with bed rest, although rarely bleeding is so persistent that bladder irrigation to dispel blood clots is warranted. Persistent gross hematuria may require embolization, whereas urinomas can be drained percutaneously. Operative intervention after blunt trauma is limited to renovascular injuries and destructive parenchymal injuries that result in hypotension. The renal arteries and veins are uniquely susceptible to traction injury caused by blunt trauma. As the artery is stretched, the inelastic intima and media may rupture, which causes thrombus formation and resulting stenosis or occlusion. The success rate for renal artery repair is limited, but an attempt is reasonable if the injury is 5 hours old or if the patient has a solitary kidney or bilateral injuries. 140 image-guided endoluminal stent placement is now employed for many of these injuries recognized by CT scanning. Reconstruction after blunt renal injuries may be difficult, however, because the injury is typically at the level of the aorta. If repair is not possible within this time frame, leaving the kidney in situ does not necessarily lead to the late sequelae of hypertension or abscess formation. The renal vein may be torn or completely avulsed from the vena cava due to blunt trauma. Typically, the large hematoma causes hypotension, which leads to operative intervention. During laparotomy for blunt trauma, expanding or pulsatile perinephric hematomas should be explored. If necessary, emergent vascular control can be obtained by placing a curved vascular clamp across the hilum from an inferior approach. Techniques of repair in hemostasis are similar to those described earlier. Injuries to the ureters are uncommon but may occur in patients with pelvic fractures and penetrating trauma. An injury may not be identified until a complication, i.e., the urinoma, becomes apparent. If an injury is suspected during operative exploration but is not clearly identified, methylene blue or indigo carmine is administered Roman 4 with observation for extravasation. Injuries are repaired using 5-0 absorbable monofilament, and mobilization of the kidney may reduce tension on the anastomosis. Distal ureteral injuries can be treated by reimplantation facilitated with a psoas hitch and slash or Bori flap. In damage control circumstances, the ureter can be ligated on both sides of the injury and a nephrostomy tube place. Bladder injuries are subdivided into those with intraperitoneal extravasation and those with extraperitoneal extravasation. Ruptures or lacerations of the intraperitoneal bladder are operatively closed with a running, single-layer, 3-0 absorbable monofilament suture. Laparoscopic repair is becoming common in patients not requiring laparotomy for other injuries. Extraperitoneal ruptures are treated non-operatively with bladder decompression for 2 weeks. Urethral injuries are managed by bridging the defect with a Foley catheter, with or without direct suture repair. Strictures are not uncommon but can be managed electively. Female reproductive tract. Gynecologic injuries are rare. Occasionally the vaginal wall will be lacerated by a bone fragment from a pelvic fracture. Although repair is not mandated, it should be performed if physiologically feasible. More important, however, is recognition of the open fracture, need for possible drainage, and potential for pelvic sepsis. Penetrating. Repair of a transected fallopian tube can be attempted but probably is unjustified because a suboptimal repair will increase the risk of tubal pregnancy. Resection at the injury site with proximal ligation and distal salpingectomy is a more prudent approach. Pelvic fracture hemorrhage control patients with pelvic fractures who are hemodynamically unstable are a diagnostic and therapeutic challenge for the trauma team. These injuries often occur in conjunction with other life-threatening injuries, and there is no universal agreement among clinicians on management. Current management algorithms in the United States incorporate variable time frames for bony stabilization and fixation, as well as hemorrhage control by peritoneal pelvic packing and /or angioembolization. Early institution of a multidisciplinary approach with the involvement of trauma surgeons, orthopedic surgeons, interventional radiologists, the director of the blood bank, and anesthesiologists is imperative due to high associated mortality rates. Fig. 770. Evaluation in the ED focuses on identification of injuries mandating operative intervention, for example, massive hemothorax or hemoperitoneum, and injuries related to the pelvic fracture that alter management, for example, injuries to the iliac artery, rectum, urethra, or bladder. Immediate temporary stabilization with sheathing of the pelvis or application of commercially available compression devices should be performed in hemodynamically unstable patients. In patients with profound shock who are at high risk based upon mechanism, for example, although pedestrian accident, pelvic stabilization should be done before radiographic confirmation. If the patient's primary source of bleeding is the fracture-related pelvic hematoma, several options exist for hemorrhage control. Because 85% of bleeding due to pelvic fractures is venous or bony in origin, the authors advocate immediate external fixation and peritoneal pelvic packing. 141. Anterior external fixation decreases pelvic volume, which promotes tamponade of venous bleeding and prevents secondary hemorrhage from the shifting of bony elements. Pelvic packing, in which 6 laparotomy pads 4 in children are placed directly into the paravesical space through a small anterior suprapubic incision, provides tamponade for the bleeding. Fig. 771. Pelvic packing also eliminates the often difficult decision by the trauma surgeon, or versus interventional radiology. All patients can be rapidly transported to the OR, and packing can be accomplished in under 30 minutes. In the author's experience, this results in hemodynamic stability and abrupt cessation of the need for ongoing blood transfusion in the majority of cases. 141. Patients also can undergo additional procedures such as laparotomy, thoracotomy, external fixation of extremity fractures, fasciotomy, revascularization, or craniotomy. Following pelvic packing, angiography is reserved for patients with evidence of ongoing pelvic bleeding after admission to the SICU 4 units of RBCs in the first 12 postoperative hours after the coagulopathy is corrected. Patients undergo standard post-trauma resuscitative SICU care, and the pelvic packs are removed within 48 hours. Prior to unpacking, however, the patient's coagulopathy should be corrected to prevent the need for repacking of the pelvic space. Repacking of the pelvic space is associated with an infection rate of 47% and should be avoided. Directed hemostasis with topical agents, suture repair, or electrocautery at pelvic pack removal should be performed. Another clinical challenge is the open pelvic fracture. In many instances, the wounds are located in the perineum and, Denver Health unstable. Resuscitate with 2L crystalloid measure. Transfuse fresh frozen plasma if FFtomy is recommended. The pelvic wound is manually debrided and then irrigated daily with a high pressure pulsatile irrigation system until granulation tissue covers the wound. The wound is then left to heal by secondary intention with a wound vacuum-assisted wound closure VAC device. Extremity vascular injuries, fractures, and compartment syndromes. Patients with injured extremities often require a multidisciplinary approach with involvement of trauma, orthopedic, and plastic surgeons to address vascular injuries, fractures, soft tissue injuries, and compartment syndromes.